Hey Megan, how you doing?
I've been better. How are you?
I'm good, thanks for asking. So, why don't you tell me a little bit about what's going on?
Yeah, so I've had this back pain for a couple weeks now. I went to see a therapist prior to this, but things just weren't getting better. They're actually getting worse. So I thought I'd try, you since I heard you're so good. So here I am.
Okay, well, why don't we talk about your pain a little bit? Can you describe to me kind of where it is and what it feels like?
Yeah, so it's in my low back. It's kind of weird. Nothing. I can't think of anything that just brought it on. I just woke up one morning and it was there, but it's kind of achy. Every now and then it's sharp, and sometimes it extends into my legs, but I don't know. It's really kind of hard to pinpoint, kind of hard to describe.
Okay, so the pain extends down into your legs. Is there anything else going on with your legs? Have you noticed any kind of sensation changes or any weakness?
Yeah, it's funny that you mentioned that. My arms, like my legs feel different than my arms, so I think maybe there's some sensation loss. It just feels different. And then I've had a lot of trouble kind of getting out of the chair lately. I never had issues with that before, so maybe it's just some weakness. I've been super tired lately, just really fatigued. So I kind of attribute it to that, but I'm not quite sure.
Okay, when you're getting up and out of the chair, when you're moving around in general, do you find that your pain is related to these kind of activities?
Um, Not really. My pain kind of comes and goes on its own. I can't really pinpoint anything specifically that brings it on. It's it just kind of happens.
Okay, so on a scale of 1 to 10, what would you say is the worst that your pain's been?
Oh wow, probably an 8. Yeah, it can get really bad sometimes, especially at night.
Okay, what's the best that it's been, and has there been anything that you've done to maybe help decrease the symptoms?
At the best, maybe a 4, but it just kind of goes away on its own. There's not a whole lot I can do for it. I've tried Advil, but it doesn't really. I don't know if it super helps. Like I said, it just kind of runs its course and then it's fine.
Okay, um, let me ask you a few questions about your past medical history. So, do you have any history either in your family or in your own personal history that might be related to this?
Um, Related to back pain, no. I mean, I'm pretty healthy. I had breast cancer a while ago. See, Link to Pink, big supporter of breast cancer awareness. But it runs in my family, so I don't know how it relates.
Okay, and did you receive treatment for your breast cancer in the past?
Yep, yep. I did chemo, radiation, and yeah, everything was fine. Kind of
Great.
got it taken care of. That was a while ago now, so
Okay, well, I'm glad to hear that. Congratulations. When was the last
thank
time
you.
when was the last time you got checked up on?
Oh, with coronavirus, it's been really hard to get into the doctor. Probably a little over a
Understand.
year. Yeah, I've been meaning to get in. It just hasn't happened yet.
Okay. Well, let me ask you a couple more questions. Have you had any fever recently?
Now that you mention it, yeah, I've had a low grade fever. I mean, I just kind of attributed it maybe to cold or allergies. But yeah, I've had a little bit of a fever.
Okay. What about any weight loss? Have you noticed that maybe your clothes are starting to get a little too loose?
Um, yeah, maybe a bit. I started a new job lately, so maybe
Hmm.
that's why. But yeah, actually, I have lost a little bit of weight. Yeah.
Okay. And then I guess my last question for you is, have you had any changes in your bowel and bladder activity?
Yeah, just a little bit of incontinence, but um, I don't know. Maybe that's just a part of aging.
Okay, Megan. Well, based on some of the questions that I've asked you, I don't think that this is something that really ends up very well with a regular muscle kind of back pain. So I'd recommend that with your past medical history and some of the symptoms that you're bringing to today, that you go and get checked out by your doctor.
Oh, wow. Okay. Yeah, I'll definitely go do that. I'll make an appointment.
Yeah. And I
Yeah.
hope that there's nothing going on, but I want to make sure first before we move forward with treatment.
Okay, sounds good. Thank you, Noah.
Yep. Thank you. Have a good day.
You too. Today we'll be going over spinal cancer. Now let's talk about the epidemiological data. In spinal cancer, your risk increases with age, and we most commonly see this in the 40 to 69-year-old age group. A lot of these patients will have a prior history of cancer. We see this most commonly in our white non-Hispanic demographic. For primary forms of spinal cancer where the cancer originates in the spine, males and females are diagnosed at an equal rate. However, in our secondary or metastatic forms of spinal cancer, males are more often diagnosed than females. We most commonly see this in the spinal cord, but we also see it in the meninges and cauda equina. And this typically most often occurs in the thoracic or lumbar spine. Moving on to our subjective complaints, a lot of these patients will complain of a spontaneous onset of their signs and symptoms. It's usually not precipitated by any trauma. They can complain of aching pain, night pain. Many of them could have received prior medical care for these symptoms and got no relief. Patients might complain of generalized weakness or fatigue, and we'll also hear about the red flags such as bowel and bladder problems, a low-grade fever, or a history of weight loss. As far as our objective complaints go, the patient presentation will depend on the location of the tumor. So we might see motor dysfunction, weakness, some vertebral body instability, and neurological complications consistent with those found in spinal cord compression or myelopathy, plexopathy, or your radiculopathies. Spinal cancer can be diagnosed in a couple different ways. This can be through a CT scan, an MRI, an FDG PET scan, which is just more specific to our oncology and cancer populations, and common radiographic findings suggestive of metastases. We have many different mechanisms of pain for the spinal cancer patients. Our neuropathic pain can be due to the direct invasion or compression of neural structures from the tumor or caused by neural toxicity, surgery, chemotherapy, and radiation. Radiation actually causes fibrosis, which can result in these complaints when affecting your neural structures. As far as nociceptive pain goes, our somatic pain is due to injured muscle, bone, or connective tissue as a result of the cancer. So we might see tumors causing vertebral lesions, bone destruction, and vertebral instability. As far as our visceral pain goes, this will occur when there's compression, infiltration, or destruction of the viscera as a result of the spinal cancer tumor. And we will always be referring these patients. So how are you feeling today?
Hey, Megan. Not too bad. How are you?
I'm good. Can you tell me a little bit about what brings you in?
Yeah. So let me just tell you, my I guess it's really kind of my whole body is achy. It's it's in my arms, my legs, my back, my neck. It seems like it's everywhere. At first, I thought, no, maybe I'm playing a little too much golf. I've been getting a little crazy since we've been in Florida on the vacation. But I don't know. I thought I'd talk to you about it.
Okay, when you say achy, is it like painful achy? Can you kind of describe where your pain is and what it feels like?
Yeah. So it's just I guess in my neck and then kind of like in the middle of my back. It just feels really stiff and sore.
Okay. Do you have any history of neck or back problems?
Well, a couple of years ago, first time we came down to Florida, it was my first time on the turnpike, and I'll let you know that they just drive crazy down here. I was in a car accident. I had some damage to my neck, pretty bad, but I haven't really had any issues since then. That was maybe 5 6 years ago.
Okay. All right. Well, so can you think of anything that brought on this pain then?
No, it's the strangest thing. It just seemed to come on all of a sudden, and I mean, it was pretty. pretty progressive, you know. It wasn't like all of a sudden it was there from one certain thing. It just crept up on me.
Okay, so you feel like it's been getting worse lately? You never had these issues before, it's just been getting worse.
No, I've never had these issues, and they're most definitely getting worse.
Okay. Um, have you had any altered sensation, maybe tingling or like pins and needles feeling in your arms or legs?
Yeah, every now and then it'll happen in my arms, but it's pretty much constant in my legs.
Okay, constant. Wow. Um, any issues with like headaches,
Mm,
anything like that?
no, no, I've never had any headaches, but every now and then it's almost like just wham, just a big piece of lightning coming through my spine.
Oh, wow.
Yeah,
Okay. And how about any history of falls, difficulty with walking, anything like that?
I told my wife, if I ever start falling, I'm getting too old. But you know, I've never fallen before, but I am starting to fall with this. You know,
Oh,
it feels like my legs aren't as strong as they used to be.
okay. And I forgot to ask Noah, how old are you?
I am 64.
Okay, yeah. Well, maybe we shouldn't be falling yet.
No,
I'll
not
keep an
yet.
eye
Too
on
early. Too
that.
young.
Yep. Have to keep you playing golf as long as we can. Okay, so I just want to look at some objective things. Um, you mentioned weakness, so I'd like to look at your strength in your arms.
Okay,
Um,
sure.
so have you noticed any difficulty, with flexion or extension?
Um, yeah, guess when I'm picking things up, it's not that bad. But when I push things away from me, I definitely do feel some weakness with my arms.
Okay, okay. Have you noticed any issues in your trunk?
Uh,
So kind of in your,
yeah, so down here, I guess yeah, I've had some sensation issues, a little bit of weakness, but mostly I think just kind of that needles that you were talking about earlier.
oh, okay, okay. Um, and just one question, we just kind of ask all of our patients this. Do you have any history of bowel or bladder problems?
You know, I don't have a history of it, but I have been having some issues recently. Yes.
Some recently? Okay. No fever?
No, no fever.
No. Any weight loss?
No, no.
Okay.
Unfortunately.
Uh, unfortunately, okay. Um, have you had any just weird, maybe unusual things or symptoms lately you want to tell me about? Like anything has anything stood out to you that was maybe a little off?
Yeah. Well, part of the reason that I scheduled this appointment was yesterday I was playing golf, and it was a long day, full 18 holes with the boys. And at the end of the day, my feet were sore. So I had my wife, you know, rub them. She's a great woman. And when she was doing it, she must have just kind of hit it wrong because all of a sudden my foot just started going like this and it wouldn't stop. It was like a good 2 minutes just ticking away.
Oh, okay. Yeah. Well, Noah, kind of based off some of the things you're telling me, I don't know if PT is the right fit for you right now. Maybe we should think about going back to our primary care provider. Do you have one in Florida?
Um, I think so. I think I'll have to ask my wife. I think so.
Okay, so I'd like you to schedule an appointment with them, and maybe get some tests done just to make sure everything's okay and make sure you're a good fit for PT before we continue, okay?
Okay, I can do that. Thank you for your time.
Okay, thank you. Have a good day.
You too. Okay, so now I'm going to be going over cervical myelopathy with low back pain. So some epidemiology data. This is more common in adults over the age of 50, and risk factors include a history of trauma to the neck, conditions resulting in laxity and congenital skeletal anomalies, smoking, diabetes, and B12 deficiency, and a history of or a concurrent presentation with lumbar stenosis. Causes can either be degenerative from osteoarthritis or from non-osteoarthritis degenerative conditions. So subjectively, these patients will have pain almost in every part of their body. They'll have neck pain and stiffness, trunk pain and stiffness. They'll be having pain in their arms and their legs with some paresthesias and weakness. The back pain from T4 to T11 is often continuous and described as a shooting or burning sensation. It's known as the false localizing sign. They may present with headaches and cramps, and they will likely have falls or complain of difficulty with walking. Really, the most consistent feature here is the progression of insidious onset. This condition will be chronic and getting worse. So objectively, they'll present with limb weakness and paresthesias. They'll have sensory loss to the trunk. They'll be having autonomic dysfunction, and there will be signs of upper motor neuron involvement. So that'll be hyperreflexivity, spasticity, clonus, and a positive Babinski and Lermity sign. To note, though, the Babinski sign has a very, very high positive likelihood ratio that is specific to upper motor neuron involvement, not necessarily specific to cervical myelopathy. The key diagnostic feature here is a visible presence of compression in the MRI. And the pain behind this is that chronic spinal cord compression leads to a chronic reduction in blood flow to the spinal cord. When you couple this with a mechanical stretch on the nerves, you get neural degeneration and an ongoing neuroinflammatory reaction. The result is progressive neuron and oligodendrocyte cell death via apoptotic pathways. And we want to make sure that we refer these patients. They need to get medical intervention, likely involving surgery. And then once we ensure that they're going to their MD first, then we can treat them.
Patient is a 24-year-old male with complaints of low back pain. So Austin, can you tell me what brings you in today?
Yeah, totally. So I've been having pain in my low back for the last 4 months. I'm a high-level squash player, and this pain has just become too much for me to deal with during my play. This isn't really the first time I've had this issue. About a year ago, I had the same type of back pain, and I went to the chiropractor, and they threw me in some type of like backbreaker 6000 type of machine, and everything got better. My pain kind of went away. Everything felt great. Got back to playing squash. But when this pain came back, I went back to the chiropractor recently and hopped right back into that machine. But it didn't really help me this time, and they didn't really know what to do with me. So now I'm here because I'm really desperate, to get back to playing squash.
Okay. Can you show me where the pain is?
Yeah, sure. So it really just like stays like into the low back area.
Okay. And how long have you been having the pain? You said 4 months?
Yes, it's been 4 months since since it flared back up, but I've been dealing with this for a year ago is when it originally started, I guess.
Okay. Do you remember if there was an incident that brought this pain on?
Nothing in particular, really. I noticed it while I was playing, but I couldn't point to a single incident that actually caused it.
Okay. And when does this pain occur?
This pain occurs when, right now, when I'm sitting, I'm having some of that pain. I can get it whenever, especially when I start to bend over, which is not good for squash because constantly I'm having to bend over to hit the ball. And then also sometimes whenever I'm coming back up into a standing position, I'll get a pain sensation that keeps me from standing all the way back up.
Okay. And how long does the pain last when it comes on?
It's pretty quick. It's kind of just a quick flare up. But the pain itself like I kind of have like a chronic or long-term pain. But when I do the motions that like cause it to get worse, it only comes on like for a pretty brief moment.
Okay. Is there anything when the pain happens that makes it better?
I haven't really noticed anything that makes it better. I mean, whenever it's really bothering me, I'll just lay down, try to get out of like a sitting position because that's bothers me.
Okay. And does the pain stay in your back or does it move like down into your legs?
No, it only stays in my low back.
Okay. And have you seen anybody besides your chiropractor?
No, chiropractor's the only person I've been to.
All right. And do you have any past medical history that you think I should know about?
No, not really. I mean, I'm pretty active and healthy, so I haven't had anything come up yet.
Okay. And now just a few questions that I ask all my patients. Have you had any recent unexplained weight loss?
No.
Do you experience any night sweats?
No.
Have you had a fever?
No, not recently.
Okay. And have you had any bowel or bladder changes?
No.
Okay. All right, so I want to move into some objective testing. Could you stand up for me? I want to watch you bend over. I'm going to show you how. Standing like to the side, I just want you to see, keeping your knees straight, bend down as far as you can, and then come back up.
Okay. Yeah, so when I started like to come down, that kind of flared it up a little bit. Ooh. And that's like that since like I feel like I'm like caught, like I can't go any further.
Okay. All right, and while you're standing, can you bend back like as far as you can go
Yeah.
without falling over?
I can try.
Okay.
That one wasn't as bad, but still a little painful.
Okay. Great. Well, I think I've collected all the information that I need.
All right, awesome. All right, so now we're going to jump into some more information on low back pain with motor control deficits. So typical epidemiological data, there wasn't much in the research about a specific population that this condition affects other than it's typically seen in people under the age of 40. So typical subjective, they'll have this episodic nature in pain, which basically means that they'll be dealing with this chronic low back pain that will frequently flare up whenever they go into a position that's more aggravating. Then they'll have reports of catching, locking, or giving way. I showed like the catching or locking in the video when they're coming back up into a standing position, they'll have this flare up that almost just makes them stop completely. They'll most often have pain immediately when sitting down, getting to that flex position. They'll have a temporary positive response to spinal manipulation. And these patients are also often self-manipulators, but these positive effects will decrease over time. And then it's chronic recurrent pain in nature. So typically they'll be dealing with this for more than 3 months. And then this will be a problem they've dealt with before. And it's non-radiating below the knees. So common body diagram, I didn't really see anything in the research to suggest whether this was more of a bilateral or unilateral complaint. The major thing to take away here is that the pain in this condition is localized to the low back and doesn't go into the legs at all. So typical objective, they'll have a painful arc of movement and aberrant motion. You may see a Gower sign or them walking themselves on their legs back up into standing, or the instability catch, which is what I talked about earlier and what I showed in the video. The specific segmental finding, you'll probably see a positive prone instability test. They'll have abnormal segmental movements, and the painful arc can often be taken away when they brace their abdomen. And then pain is going to be at rest or in the initial to mid-range spinal movements. They may also have low back pain with palpation or provocation of that involved spinal segment. Trunk or pelvic muscle strength and endurance will be decreased. And then they also may have a positive Beighton showing general laxity. Key diagnostic features. So there's 4 key factors that show they will respond better to stabilization exercises, which is the preferred treatment method for this diagnosis. And that's going to be that if they're less than 40 years of age, if their average straight leg raise is greater than 91 degrees, if they have an aberrant motion in lumbar flexion, and if there's a positive prone instability test. So mechanism for symptoms. So for proper neuromuscular control, spinal segments, our structural, muscular, and neural control systems all have to be working together. And without this, it'll lead to a lack of segmental control, and a lack of osteoligamentous stability would lead to decreased spinal stability. And this is especially the case for muscular and neural control systems, and the fact that they wouldn't be able to compensate for the lack of osteoligamentous stability. So treat or refer, we can definitely treat these patients with the stabilization exercises like I talked about earlier. However, if this is a problem that they've been dealing with for a really long time, or if they're showing any other red flag symptoms, this may be something that you want to refer back to a physician as well.
Hey, Taylor, what brings you in today?
Hey, so I just have this pain in my back, and I really need it to go away because I need to get back to work, and it hurts.
I hear you. Can you tell me a little bit more about that pain?
Yeah, I have it like in my low back and like in my butt area, kind of, like on this like left side.
Okay. It's just on the left side?
Yeah, like only on the left.
Okay. Have you had this before, or is this something new?
No, I have never had back pain before, so it's just there.
And how long would you say this has been going on for? Is this recent, or it's been going on for a little while?
So, with like Rona happening out there, I lost my job and I had to find a new job. And so I was looking and I was like, where do I get a new job? Amazon. Amazon didn't shut down because of the Rona. So I started working there, and they have me like lifting boxes and stuff. And lifting boxes, but I don't know. And so I guess I just like lifted one and it hurt. And so it's been like a week and a half now, and Amazon's really serious about getting it checked out.
Okay. And have you had any tingling or numbness, any kind of sensations like that going down your legs?
No, unless I like sit on my leg for too long, but that's always happened.
Okay. Is there anything that makes the pain better or worse?
If I like rest and don't try to like move a lot, then it doesn't hurt. But then when I get up, it kind of hurts.
Okay. And on a scale of 1 to 10, say 10 being worst pain, send me to the ER, 1 being, don't care about that, what would you say your pain is?
I would say like constantly a 3, but it definitely gets up there when I have to like move around and stuff.
Okay. Does it feel like a dull, achy pain, or is it more sharp?
It's a dull, like just always there, just like an annoying ex-boyfriend kind of pain.
I hear you.
Yeah.
Are you taking any medications for this or anything else?
No, I had like a very holistic approach, so I don't really like to, but sometimes I'll like sneak in acetaminophen or something.
Okay. Are you seeing anybody else for this, or you just came to PT first?
I just came to you, Dr. Galliford. I thought you were going to be the one that fixes my back.
Got you. Have you had any other injuries with your back or anything else, or any other medical conditions that should be concerned with?
No, I'm a very, very healthy 25-year-old.
Perfect. Have you had any unexplained weight loss or weight gain?
I mean, it is summertime, but the summer, like hot girl summer isn't really happening right now. So no.
What about any sudden fevers?
Oh, like the Rona? No.
No, no night sweats.
No.
Any bowel or bladder changes?
No.
No. Okay. Well, that's I think all we have for the subjective, and we'll go to the objective.
Cool. Thank you. Cool. So we're going to throw it back to MSK with Dr. B, Dr. KLM, and Dr. Dunleavy and talk a little bit about low back pain with mobility deficits. So unfortunately, the epidemiological data, there's not a lot on it. Low back pain is very common. The biggest thing I noticed in the research was that females get it more than males, but there was no age difference or anything like that. So that's all I have for that. The body diagram is also not that exciting. I did 3 lines right there just to show that it is unilateral, most often unilateral, and that you can feel it in your low back area, but can also come down to your buttock and thigh area if need be. So the good stuff, the subjective, you're gonna have acute low back pain or subacute if it's longer than a little bit, low back, buttock, or thigh pain. It's typically unilateral. You can see it bilaterally, but in, again, most of the literature, it talks about a unilateral pain. And onset is typically linked to recent unguarded awkward movement or position. So if you refer back to the Amazon young lady that I was picking up a box, I had an awkward movement, and then I had back pain afterwards. So that's usually where you see with that. So the fun stuff, the objective examination and the key diagnostic features. So big things to remember here is that you're going to see restricted lumbar range of motion. When you test the segmental mobility of your lumbar spine, it's going to be very limited. You're going to do a prone instability test, straight leg raise, slum test. All of those are going to be key findings there. MMT is not going to be that strong, especially because you're going to have all that restricted range of motion. And big things to know here is your hip passive range of motion is going to become important too. If we switch over to the key diagnostic features, you'll see that internal rotation of greater than 35 is one of the clinical prediction rules for low back pain with mobility deficits. The rest of those key diagnostic or clinical prediction rules are going to be recent onset, so less than 16 days. I had gotten injured 2 weeks ago. A low FABQW, so less than 19. No symptoms below the knee. So when I reported my pain, I had that low back pain and I had slightly in my butt, but I didn't have anything down radiating in my calf or in my foot or anything like that. And lumbar stiffness. So overall, you're just going to feel incredibly stiff. Mechanisms or symptoms. So pain nociceptors become irritated due to an inflammatory response, and those inflammation processes usually occur due to irritation of your synovial joint. So treatment, what would we do? We would treat. Don't worry about referring for this one. And then treatments are just things that we've learned in MSK. So joint mobilizations, therapeutic exercise, so working on core stabilization, lumbar strengthening and stretching, and hip strengthening and stretching, as well as education on posture and other ADL body mechanics. Something that's really important to remember is that for low back pain with mobility deficits, a distinguishing movement or pain characteristic that is important is going to be that restricted spinal range of motion and segmental mobility. And that the patient's low back or low back related symptoms are going to be reproduced with provocation of the involved segments, and the intervention strategies are going to focus on fixing those. So throwing it back to MSK, that was a little information for you there. Let us know if you have any questions.
So patient is a 72-year-old female with low back pain. All right, Mrs. Mack, how are you doing today?
Oh, I'm pretty good. How about yourself?
I'm doing just fine. So why don't you tell me what brings you in today?
Okay, well, I was dusting my house a couple days ago, and it stirs up all the dust, and then I sneezed, and then I felt this really sharp pain in the middle of my back.
Okay.
That's why I'm here.
All right. Have you found anything like a position or a movement that brings on this pain?
Yeah, it's worse if I bend down and pick something up. If I change my positions. Oh, coughing. Yeah, that brings it on too.
Okay. Have you found anything that makes it better?
Uh, really just if I lie down.
Okay. Can you go ahead and take your finger and kind of just point to the area that's bothering you?
Oh, yeah, just a second. Can you see me? It's right here.
Okay. Is that like right in the center of your back?
Yeah, it's right here in the middle. Can you see this?
Yeah, yeah. It looks great. Perfect. All right. So can you describe that pain? Like, is it sharp, dull, throbbing, or aching?
Uh, well, when it first happened, it was pretty sharp. But then now it's more kind of dull, I would say. It
Okay.
really only like it'll get worse if I, like bend down or when I cough, but it's mostly just dull right now.
Okay. I gotcha. Any numbness or tingling?
No.
Okay. And does the pain go down like into your legs at all?
Oh no, it just stays there in my back.
Okay. All right. So I know you mentioned like bending over and coughing really bother you. Are there any other like activities or hobbies that this injury has kind of been keeping you from doing?
Uh, just chores around the house, laundry, cooking, putting the dishes away. My husband has not been happy that he's had to help with that. you know.
I can imagine. Um, does your pain stay constant or does it change throughout the day?
Uh, it's like the constant dull, and then if I do one of those things, then it gets worse. But
Okay.
mostly dull.
And on a scale of like 0 to 10, 0 being no pain at all, 10 being like worst pain imaginable, like you have to go to the ER, what would you say you're at right
Right now, 4.
now? Okay. And then what about when the actual injury occurred?
That was a 7. Yeah, it was pretty
Okay.
sure.
A little bit higher for sure. Any past medical history that need to be aware of, like a history of diabetes, hypertension, cancer history?
Uh, well, let's see. I broke my wrist a few years ago. I am lactose intolerant, so my doctor says I don't have enough calcium. Um, you know, what are you gonna do?
Okay, I'll make sure to make a big mental note of that. Is there any past surgical history I need to be aware of?
Uh, no, I don't remember having any surgeries.
Okay. Do you smoke or drink alcohol?
Oh, well, I used to be a smoker. I quit like 2 years ago. But, when you go to football games and stuff, like it just back when I was younger, it was just so cool to be ripping a cig with your friends. But my doctor says that I have osteoporosis or something. And so he said I should stop smoking because you know, it'll make that worse. So I quit smoking. Still miss it, but anyways, here we are. Do I drink? Who doesn't? Am I right? I have a few drinks a week. Usually when I'm watching sports with my husband.
Okay. But it's been 2 full years since you've stopped smoking.
Yeah, I'll have a cigar every once in a while just for fun.
Okay. How often would that be?
Twice a year.
Okay, so not very often. Not as often as you used to be smoking.
No, no, no.
Okay. And then have you seen anyone else for this back pain?
No, just you. My husband said I had to come see you because he doesn't want, something bad to happen. And then he really has to do all the chores, not just putting away the dishes. But, we just love watching Gator sports and keeping up with football recruiting. Did you see we got Kamar Wilcoxon again? We'll see if he actually stays with us this time. I'm sorry for rambling. I doubt you even keep up with college football. Did you have any other questions?
No, but I agree. He's an absolute diva. I just have one last set of questions, kind of just something we like to call red flags, something that we just have to ask about in every patient.
Oh, yeah, okay.
Had any fever?
No.
No? Any nausea, vomiting, unexplained weight loss,
No,
night sweats?
no.
Okay, all right. So that's really all the questions that I wanted to ask. We can move on into some more of our testing. So first thing I kind of want to do is take a look at your posture. So if you can kind of just sit back in your chair for me. I'm just going to take a look at your posture from the front.
Oh, hold on, let me see. I just got my hair done.
It looks great.
Thank you. Can you see me?
Yes, I can see you. And then can you now turn to the side for me? Okay. And then if you don't mind, can you take a finger and kind of poke or touch where the pain has been feeling and tell me if that brings on the pain?
Oh, yeah. Yeah, that does bring on the pain.
Okay, so that does. Okay.
Mhm.
All right. Well, that's really all I have for you right now. And I think that I have an idea of what diagnosis it is.
Okay, compression fracture. Epidemiology, it's the most common complication of osteoporosis. So it will have the same risk factors as osteoporosis, like smoking, excessive alcohol, calcium and vitamin D deficiency. It's a lot more common in females than males and over 50 years old. So it commonly happens after menopause in females. So your typical subjective, if it's an acute fracture, they'll say they had an abrupt onset of pain with position changes or coughing or sneezing or lifting. And if it's a chronic type of fracture, they would have noticed a gradual loss of height. In your typical objective, in the acute fracture, you'll see the kyphosis, and they will have midline spine tenderness between T8 and L4. So just as a reference, T7 is at the inferior angle of the scapula, so a little bit below that is T8, and then anywhere in there, they won't probably complain of pain on that entire line that I drew there, but at one of those spots in between there. And then the chronic fracture, you'll see kyphosis and again that loss of height. So key diagnostic feature, the clinical prediction rule is if they're over 52 years old, no presence of leg pain, BMI less than or equal to 22, they don't exercise regularly, and female gender. If you've ever seen SpongeBob, this little lady can help you remember this clinical prediction rule. She checks all 5 boxes. So the negative likelihood ratio is pretty good if there's 2 out of 5 or less. And then the positive likelihood ratio for if there's 4 out of 5 or more. Mechanism for the symptoms, if there's bone pain is often caused by hyper-remodeling of the bone, which involves the osteoclast activity and the modification of bone innervation. So bone mass and strength decline with age, but the density of sensory nerve fibers in the tissue do not decline in older age. So this can contribute to their pain. And then over time, multiple vertebral compression fractures may lead to progressive loss of stature and continuous contraction of the paraspinal musculature to help maintain their posture. So this combination of events results in fatigued muscles and pain that may continue even after the original compression fractures have healed. So you can treat or refer. Compression fractures are often handled by conservative treatment. However, if they're having any lower extremity neuro symptoms that are not attributed to any other diagnosis, it could be that the compression fracture is compressing on the spinal cord, and so you'd want to refer them for that. Or if they're not responding to conservative treatment, then you can also refer them.
Hi, Billy. How can I help you today?
Hello. Do you mind if I smoke in here? I haven't had one in about 5 minutes, so.
We prefer that you wouldn't, but you're kind of in your own home, so you
Well,
can do what you want. But if it distracts you, you can put it down.
I think I'll keep it for now. So the wife, I told the wife that I was having some stomach pain and a little bit of back pain, and she told me, go see the therapist. I saw the therapist before, and they took care of my pain. So I'm here, and that's my story.
Okay. Could you actually point with your finger or your hand where you're experiencing the pain?
Yeah, it's a little bit hard to tell on the tele camera. But my belly button's here, and the pain is about like right here. And then sometimes, not always, I got pain in the back right here.
Okay. Does it tend to be on one side more versus the other, or pretty much the same?
It's about the same. It's really hard to describe. I wouldn't be able to have a conversation about it really. It's just like this deep pain. It's in there, and that's all I can tell you.
Okay. Do you experiencing any like radiating symptoms, maybe down your leg or in other places of your body?
Nope, it stays right there in the stomach and in the back.
Okay. How long does this pain usually last?
Oh shoot. I'd say it lasts about a couple hours at a time. Yeah,
Okay.
because I watch about 4 episodes of Law and Order, and then at the end of that, then it's pretty much gone. Yeah.
Okay. And then if you could rate your pain right now, 0 being no pain at all, 10 being emergency room pain, what would you say it is out of 10?
You people, you always do this. I came here and I had pain, and now I'm here and I don't have any pain.
Sorry. Have you found anything that makes your pain come on?
I haven't been able to. My wife told me to log it. I started logging it, and I can't find any patterns. It's just on for a couple hours and then off, and then on for a couple hours and then off. There's no pattern to it.
Okay. So you can't do anything that makes it better?
Not really, no.
Okay.
Just kind of wait it out, and I've gotten good at that.
Okay. Could you tell me a little bit about your past medical history?
Oh, okay. How much time do you have?
Okay.
Pretty much anything for the heart, knock me down. Coronary artery disease, mark me down. Family history of it, mark me down. They've all got it. High blood pressure, you guys call that the hypertension. Okay, yeah, I got that, mark that down. But the one thing I don't have is the sugars with it, and I'm pretty proud of that one. There's no sugar disease over here.
Good. Okay. Well, thank you for letting me know about those things. I do see that you have a history of smoking. How long have you been smoking?
Oh shoot. I would say since I was about first job since I was about 16. Yeah.
Okay.
Relax after work.
Okay. And then what do you usually do to get like your physical activity of the day?
It's funny you ask that because my wife asks me the same thing after she gets home from work. Nothing.
Okay.
I get up, I go to the fridge, and I get back down and I sit on the couch.
Okay.
And what?
Okay. So then the last couple questions I have to ask all my patients just to make sure that physical therapy is appropriate for you. So are you experiencing any severe night pain?
I'm a pretty heavy sleeper, so it doesn't usually bother me until I wake up.
Okay, so you have pain right in the morning when you wake up though?
I would say, yeah, I'd probably start my day with a little bit of pain.
Okay. Are you experiencing any bowel or bladder dysfunction?
No.
No? Any unexplained weight loss?
Nope.
No? Okay. So that's the end of my questions for you. So we're going to move on to more objective testing, which is going to help me kind of rule in or rule out some of the diagnoses that I'm thinking.
Okay.
So the first thing is some range of motion. So if I could have you stand up for me, please. And you're just going to put your hands on your hips.
Well, let me put down the cigarette.
Hands on your hips. And then turn to your side for me so I can see you a little bit better.
How's
Good,
this?
thank you. And then just bend forward as far as you can. Okay, does that bring on your symptoms at all?
Nope, not at all.
Yep. Okay. What about bending backwards? Does that have any symptoms?
Nope.
No, okay. And then what about sliding your right arm down your right leg? Almost like you're side bending. Can you let me know if you have any pain with that?
I don't feel anything.
Okay, what about your left side?
No pain.
Nothing with that? Okay. So that pretty much looks normal. So the last thing I'd like you to do is, so right above your belly button where you're saying you're experiencing that like pain and like deep pain that you're describing, could you just like with your hand kind of put a little bit of pressure, like you're palpating around, and tell me what you feel.
Well, I don't know if this is some kind of witchcraft or something, but I can feel my heartbeat a little bit.
Okay, kind of like it's like pulsating?
Yeah, I would use that word.
Okay. So I think I have everything that I needed, and to me it sounds like physical therapy might not be appropriate for you, and I think I want to refer you out to your primary care physician to get a better look on what we're dealing with here. Does that sound okay with you?
That's fine with me.
Okay, so if you could make an appointment with your primary care physician and I'll check up and make sure you did that.
All righty. Thank you for your help today. You've been really kind.
Yep, thanks, Billy.
So these patients are typically Caucasian males who are greater than 60 years old, and it's not uncommon for them to have a family history of AAAs. And then personally, they have a history of smoking, hypertension, atherosclerosis, and then any other cardiac disorders along those lines. And then one thing that I found interesting was that this diagnosis has a negative association with diabetes, and that just simply meaning that these patients don't typically have diabetes. So for our subjective, most individuals are asymptomatic, and of course I played a symptomatic patient because that was my reasoning for coming to PT in the first place. And the location of the pain is dependent on the location and size of the aneurysm. So if we come down here to the pain diagram, we can see that a proximal aneurysm will cause more of this upper umbilicus pain and can refer pain to the back down here. And then a more distal aneurysm will have more pelvic pain that can refer pain to the groin and also to the upper leg. And this can be on either leg. Their pain will last for hours at a time. Nothing really makes it better and nothing really makes it worse. For the objective, we may find a pulsating abdominal mass that's at or above the umbilicus. And remember from Dr. Med's lecture that we want to avoid deep palpation if we suspect a AAA. And then pain cannot be provoked by movement, and that's really what we were trying to get across in the video when Maddie was having me do all different types of positions, and I presented with no pain in that moment because we wanted to really emphasize that nothing Maddie would do would recreate the pain that I feel. And then you may also sense a presence of a bruit on listening to systolic or diastolic pressure. And then these signs of a dissecting AAA are also really important because this is more of an emergent case. And this will be severe sharp pain. They may have more pain laying in supine. They may hear their heartbeat when they're lying in supine. The mass we were talking about earlier may be tender, and they may have more of a drastic decrease in blood pressure. So the mechanism for symptoms, the pain can be caused by the aneurysm just pressing on the surrounding structures. Or if there's a more focal pain, it could be caused by just the rapid growth of the aneurysm. And then as we talked about a little bit earlier, with the leg pain, this can be caused from a blood clot or debris that is coming from the AAA that can block blood flow to the legs. And then we, of course, want to refer these patients out. We want to inform their primary care physician and get them seen as soon as possible. A diagnosis for this disorder can only be made through ultrasound or a CT scan. And then with that, they'll just monitor the growth of the aneurysm, monitor the patient's diet, try to get the cholesterol down, usually try to get them to stop smoking. And then they may also include surgery if the aneurysm becomes to a certain size.
Hi, this is an ankylosing spondylitis case. I'm a 40-year-old male with back pain.
Okay, so hi Jerry, how are we doing today?
You know, I'm doing pretty good. I've just got some back pain that's kind of been nagging on me, so I figured I'd come in and to PT and see if you could help me out.
Yeah, well, we appreciate it, and we're going to do everything we can to get that back pain resolved for you. So why don't you tell me a little bit about this pain? How long's it been going on?
So, I mean, I've had chronic back pain for about 10 years or so. You know, it's always kind of nagged me. But the last few months, it's just really been acting up. I don't know, it might have something to do with, I've been home a lot. I like to garden, so with all my free time, I've been working on my gardening. I just picked some mangoes.
Oh wow, look at those.
I mean, too bad. I wish I could give them to you.
I know.
Off the tree. So
They
anyway,
look delicious.
over the last few months since being home because of COVID, been doing more gardening. It's just been acting up a lot.
Okay. And when you say acting up, do you mean it's more intense, more painful?
Yeah, I just say it's more often.
More often.
Yeah, it's a little bit more intense than it was usually, I guess.
Okay. And is it a pain? Is it a numbness, a tingling?
It's mostly like a stiff and achy feeling in my low back.
Okay, so stiff and achy.
Mm-hmm.
And how intense would you say this stiff and achiness is out of 10 if you had to give it a number?
Maybe a 5 out of 10.
Okay. Is that right now or on average?
So it's definitely the worst in the morning when I wake up. I'd say it maybe starts at about a 7, and then through the day it kind of decreases to maybe a 3, just kind of stiff and achy all over.
Okay. And so would you say that it gets better when you are moving around?
Yeah, so I've actually noticed it's the weirdest thing when I'm doing my gardening and stuff. It's actually better. I notice it kind of goes away for the most part.
Okay.
But then when I sit for a long time, it acts up. My wife, she makes me watch these silly chick flicks with her in the afternoons, evenings, and after a few hours of sitting on the couch, you know, it just flares right back up.
Okay.
Yeah.
Is there anything else that makes it any better or worse?
Not specifically, no.
Okay.
That's it.
Other than that, have you had any history of any other medical conditions that you can think of? Anything that it might not seem relevant, but anything that I should know about?
You know, occasionally I get some of that similar stiffness in my neck.
Okay.
It kind of goes with the same pattern. I notice.
Worse in the morning.
Yeah, it kind of goes along with that same pattern, but it's not terrible. So I just kind of blow it off.
Okay. What about do you have any other medical conditions, any arthritis?
Yes. And so I have Crohn's disease. So
okay.
I've had that for a few years, but I manage it pretty well. I grow most of my own food, so I eat pretty healthy. But actually, because of COVID, my medication is on back order. So I've been cutting back on my doses to try and last me until it's back. So I don't know, that might have something to do with it.
Okay.
Yeah.
Has that cutting back on your doses, did that happen around the same time that the back pain started to get a little worse?
It did actually.
Okay.
I did notice that actually. And then I've also been getting some itchiness and some flare-ups in my eyes. But I just kind of say, nah, I try to avoid going to the doctor. I hate the doctor. So I try to if I have too.
Okay. Any other symptoms with your eyes? Any loss of vision? Anything like that?
No, just really itchy sometimes, especially in the mornings. Yeah.
Okay. Same type. Okay, in the mornings.
Mhm.
Gotcha. Have you had any bowel or bladder issues?
No, those have been all.
Any weight loss? Any fatigue?
So actually, I have noticed my britches have been kind of falling off of my behind lately.
Getting a little slimmer, maybe?
Yeah, and it's not from a lack of eating, that's for sure.
Oh, have you increased your working out or anything? Or
No,
did it just kind of come out of nowhere?
it's been out of nowhere. I mean, I've been picking up with my gardening lately, but not crazy. I used to be able to be out in the garden 7-8 hours a day, but now after a few hours, I need a breather. Come in, get in the AC.
Oh, you're a little more tired?
Yeah, I have noticed some extra fatigue lately. So.
Okay. And how much weight are we talking that you've lost? Have you put any numbers on it? Stepped on the scale at all?
I haven't actually measured it, but I think I've lost a size or two in my drawers.
Okay, a size or two.
Yeah.
All right. Anything else before we maybe get up and moving that you can think of that you want to tell me?
Nothing else that seems very important.
Okay. Well, the next thing that I want to have you do is, can you maybe sit up tall for me? Just want to see how we're doing. Okay. And what we're going to do now is if you can stand up and go behind your chair, I'll do it with you. We're going to do a little bit of motion. Okay. See how you're moving. All right. Okay. So can you bend forward for me? Try to bend. Any symptoms with your spine there?
Not too bad. This is about as far as I can go.
Okay. How do you feel? Does it feel stiff at all?
A little stiff.
Okay. Any pain with that?
Just some stiffness.
Okay. And what about if we go backwards? If you arch your back.
Not terrible. Just stiff.
Okay. And what about if we go to the side, reaching one hand down towards your knee and down towards your foot if we bend there?
That's about it.
Okay. And the other side?
Oh, just some stiffness all in the low back.
Okay. And then we can actually sit back down in the chair for a second. Okay. If you grab the back of your chair here and try to turn, maybe grab your chair and your leg and try to rotate. Okay.
Yeah. I'll try the other side, see if that's any better.
Yeah. The other way.
Not much better.
That's all right. Everybody has a little bit different range of motion, but that stiffness might be contributing to some of your pain. So it's good that we know about it.
Okay.
And if you reach behind you and kind of press on your spine at all, any bony parts that you can feel, does any type of pain come from that?
It's a little tender.
A little tender. Where are your hands at? Do you want to maybe stand up and show me where you're feeling?
So it's pretty tender right in there.
Okay. Do you want to maybe turn a little so your back is facing me and I can see your hands? Oh, excellent. Thank you.
Yeah. It's a bit tender.
Okay. Just all through there?
Some tenderness kind of out here and here.
All right.
Some of that pain kind of goes down my butt at times.
Okay.
So.
Well, Jerry, I think your symptoms are pretty consistent with something we call ankylosing spondylitis. So what we're going to do is give you some exercises here in the clinic and hopefully help out your symptoms, okay?
Okay, thank you. Common epidemiology findings of this condition persist of a higher prevalence among males, an early onset in adulthood, higher in Caucasians, and individuals will have the presence of HLA-B27 gene. Common subjective of patients will include a chronic back pain with unknown origin. They will usually complain of pain in the low back and hips. However, this condition can progress to any joints throughout the spine or in the periphery. They will have worse pain in the morning and periods after inactivity with no improvements in rest. Pain will they'll complain of an achy, vague pain and stiffness that decreases with activity. Some patients may experience weight loss and fatigue, and it is very common for these patients to have other inflammatory conditions. The pain diagram, like I said, it usually starts in the low back and hips, and it may extend down the thigh and buttock. However, it can present in any joint throughout the body. Objectively, patients will be tender upon palpation of the spinal process and SI joint. They'll have painful and stiff movement. They'll have aberrant motion with trunk flexion and decreased lumbar motion in all plane. They'll have a decrease in lumbar lordosis, present positive with special SI special tests, and they may have alternating unilateral buttock pain extending down the thigh, and they may have hip flexion contractures as well. Key diagnostic features include radiographic findings of fusion of the vertebrae or other abnormalities consistent with sacroiliitis. Mechanisms and symptoms. So the pain is actually caused by an interaction of elements between a genetic component as well as an immune component, and basically it causes an inflammatory reaction at the synovium of the joints, causing a breakdown in inflammation at those joints, triggering a nociceptive response. So what do? Treat and refer. Currently, there is no cure for the condition. However, we can be very helpful in their management of the condition. We can provide education on postures and body mechanics, as well as provide interventions including mobility, flexibility, strengthening for their core and their trunk. However, we also want to refer them for medical management for them to get imaging and medication.
All right, so this is a patient with lumbar radiculopathy and radiating pain. And my name is Daryl as the patient, and Haley's going to be evaluating me.
Hi, Daryl. How are you doing today?
I'm doing all right. I've been better, but...
Can you tell me about what's going on with your back?
Yeah, so it's the strangest thing. I've been a truck driver my whole life, and, all these years, no problems. And then lately, I've been driving, and my back starts to hurt a little bit, and my legs start to feel like a little tingly, like they're going to sleep. Mm-hmm. Sometimes like my foot, I feel like, it goes to sleep and I can't feel the pedal, which is not good when you're driving a truck. Mm-hmm. And sometimes there's pain. So it's kind of just like a whole mess of symptoms.
Yeah, it sounds like it. When did you notice these symptoms first start?
I can't really put my finger on it, but maybe like a month ago.
Okay. Was there anything around that time that you remember happening that brought this on?
No, they kind of just snuck up on me out of nowhere. Nothing, I didn't fall or nothing, which is what I would think would hurt my back, but it just, I was just sitting one day and there it was.
Okay. And can you show me the location of where that pain is in your back?
Yeah. So it's like down here a little bit. Mm-hmm. And then I get the tingling all down the back of my leg and then down to my foot down that way.
Okay. And how would you describe that pain in your back? Is it like a burning or more of an aching?
It's kind of like just uncomfortable. Okay. It's like, if I was laying on like a rock, that's what it feels like. It just kind of hurts a little.
Okay. And you said with driving, that's usually when you feel it the most. Are there any other activities or postures that you notice bring on these symptoms?
Driving's when I feel it the most. Sometimes if I'm sitting watching the old television, then I'll start to feel it and I'll have to get up and go
maybe make myself a snack or something, and then I, walk it off a bit, and it seems to help a little. But I don't know. I'm no doctor.
Okay, so you notice it gets better when you're up and moving around.
Yeah, it feels like it a little bit.
Okay. So if you had to rate your pain on a scale from 0 to 10 right now, how is that pain currently?
Right now, it's probably like a 3.
Okay. And the worst on that scale in the last day or two?
Ooh. The other day I was really driving. I did a cross country haul, and it got up to probably like a 7.
Oh, wow. Okay. Are there any other symptoms that you notice when these symptoms come on? Is there any other symptoms in the rest of your body anywhere?
No, I mean, my arms are good, nice and strong.
Yeah.
Nothing else in my body. It's just that back, my back has a little bit of pain, and then my legs, they get that weirdest feeling, that little tingling, and that it's like I'm getting stabbed by 1,000 little needles.
And do you notice any weakness with these symptoms?
Yeah, when I get out of the truck, when I stop, when that happens, sometimes it's hard to walk at first. Like my legs done forgot how to move.
Yeah.
They just can't hardly hold me up.
Okay. Do you have any other medical conditions that I should be aware of?
No. I mean, my doctor says we're keeping an eye on my cholesterol numbers, but that's all I can really think of. I usually been in pretty good health.
Okay. So just a few other questions before we move forward. Have you noticed any fever associated with your symptoms?
No, I haven't been sick in a long time.
Okay. What about experiencing night sweats?
I mean, I'm a big boy. Sometimes in the South it gets hot, but not any crazy sweats, just the regular ones.
And have you noticed any unexplained weight loss recently?
Oh, don't I wish? I mean, I could go for a few unexplained pounds out the window.
Okay. And also, have you noticed any changes in bowel or bladder function?
No, we're still running smooth.
Okay. And another question, have you noticed this pain? Does it ever wake you up at night?
No. I feel like generally at night it's, I can sleep.
Okay.
But I get pretty tired during the day, so I just kind of knock out. Okay.
Overall, how is this impacting your life most?
Well, I'm a truck driver by trade, and it's really affecting my driving. Can't go the distance I used to without stopping, and it's really hurting me during the long drive. So I really would like to get it taken care of so I can get back at it and, keep driving without having to think about it.
Of course. All right. Well, moving forward, I'm just going to do a few things, get you up out of your chair and check a few things out and see if we can figure out what's going on.
Okay.
So this first one, if I could have you stand up and then just turn to the side for me so I can see that nice posture of yours. All right. This next one, I'm going to have you bend forward at your waist and try and touch your toes.
Ooh.
Is that painful? Does that brings that pain on in your back?
Yeah, it hurts a little in the back, but I get that shooting, sting in the back of my legs.
Okay. And if you go back, if you extend your back, do you still experience that pain?
It don't feel great, but it's not the worst.
Okay. And the next one, can I have you bring this arm down like you're coming down to that knee? Right. And then the next, we're going to go to the other side. Good. All right, and then this next one, I'm going to have you back in your chair, sitting down. And then I'm just going to have you try and bend in that spine. Rotate.
Yeah, I don't know if I got as much motion as the younger folk.
Yeah, and then, yeah, the other side too. Does that bring on your pain?
I just feel a little stiff, you know. I don't really have a lot of mobility in my old bones.
Yeah, as we get older, that unfortunately tends to happen. All right, so before we move on, I'm going to do one more thing. I'm going to have you come to the side for me to try to get a good view for you. All right. So what I'm going to have you do, you're sitting down.
Yeah.
I'm going to have you bring your leg up and then bring your toe towards your face.
Okay.
And then I'm going to have you flex your head down like you're looking down to the ground. Does that bring on your symptoms?
Yeah, that's them.
If you bring your head back up, keeping that foot there, and then bring your head back up, does that decrease your symptoms at all?
Yeah, you know it does.
Yeah?
That's the darndest thing.
Okay, well, that's going to be it. I'll have you finish up the PowerPoint.
My portion of this is lumbar radiculopathy with radiating pain, like we just saw in the case. You might recognize this. This is one we talked about in MSK. It's a very common diagnosis, very common condition. Estimates show between 3 and 5% of the general population have this, and 12 to 40% of low back pain patients. So, 40% is almost half of all patients with low back pain might have this. So definitely something to keep your eye out for. Typical subjective, it's any one or combination of the following symptoms in the lower extremity. So numbness, weakness, pain, and then you might see loss of reflexes as well in the lower extremity. Thinking about the type of pain that it is down that nerve. So the typical objectives you would see would be a slump test would be positive, straight leg raise test also positive, and then depending on the nerve, femoral slump could be the one that is aggravated, so femoral nerve, and then so that would be positive, and then again loss of reflexes in the lower extremity. So the key diagnostic features, this one, it's the neurological findings that lead you there, but they're not necessarily unique to only this diagnosis. So it's really the pattern of symptoms that lead you here. It's low back pain with that neurological findings, and that total picture will be the key in terms of what gets you to this diagnosis. And the mechanism of symptoms, this is just the noxious stimuli of the spinal nerve. So something's going on where the spinal nerve is either compressed or, something's going on in the spine, and that is causing a distribution of symptoms, pain, numbness, tingling down the leg and into the lower extremity. And there's a number of things that can cause this: disc generation lesions, degenerative disease, posture, extended positions. So, a number of things can cause it, but that's the mechanism, and it makes a lot of sense if you think about it. And so what do we do for a patient with this? You can treat them. A lot of good evidence is shown for physical therapy and conservative treatment. So manipulation, nerve glides, strengthening exercises, and traction are all ones that I found in the literature that have good results. If the patient doesn't show any improvement after what would be a reasonable period of time, you could refer them as well. Maybe you would want to get some imaging to see just what, if they have very severely degenerative disease or something like that. But as a first line of treatment, conservative treatment has a lot of good evidence.
Hi, Mr. Galliford. How are you today?
Hey, Mama, I'm doing good. How are you?
Fantastic. Thank you for asking. I just have a few questions for you because I know you came in for some low back pain, but I figured you could tell me a little bit more about that.
Yeah. And listen, the thing is that it hurts in my back, like right in the middle. And, yeah, it's been getting pretty bad.
What kind of pain can you tell me? Is it a sharp pain, a dull pain?
Yeah, I feel it there. And then I've been feeling some stuff in my legs. I don't know. So that's been kind of worrying.
When you say feeling stuff, what does it feel like in your legs?
Like funny sensation. I don't know what would you describe that as?
Kind of like pins and needles
Yeah, some things like that. Yeah, I've been feeling that on both my legs.
on both of your legs. How far down does it go?
I'm not sure, for sure down the back, like at least, the back leg area.
Okay. How long has this been going on for?
It's been going on for a little while. I'm a little old. I came from Cuba like 35 years ago.
Wow.
Uh,
Okay.
so I'm a little bit older now. So I guess that's probably why this is all happening.
I can't even tell. You don't look a day over 35.
Stop it, girl. Stop it.
Can you tell me what makes your pain worse?
Yeah, standing. So recently, we'll be playing dominoes outside with my friends, and yeah, that feels better when I play. I feel good, but then when I get up, as soon as I get up, I feel it in my back, and I try to go for a little walk, and as soon as I start walking after a while, oof, the pain comes on, and then I start to feel. What did you say those things were in the back of my legs?
Pins and needles.
That one, that I feel. And then yeah, when I sit back down, I come inside and I tell my wife, hey, oof, I was feeling these weird things. As soon as I sit down, it starts to feel a little bit better.
Okay, good. So sitting helps. Is there anything else that helps it?
And no, mostly just like in a sitting position like that. And, when I have my cigar and a little whiskeycito, that feels better also. But I'm sure that's different.
Yes, it's a little different. Do you take any medications for it?
And sometimes I will, but I'm not a big medication guy. Like I said, my medication is what I mean.
Cigars.
Yeah.
Okay. Have you had any sort of back pain before or any sort of injury to your back or anything that I should be aware of?
No injuries. It's just I'm getting old. I feel it in my back. I'm not as active as I used to be. I'm feeling a little weaker too. I don't know if that's the old age or maybe something else is going on, but it's been like that. It's been getting a little bit more and more like that.
Okay. Um, I have a few weird questions to ask, but just to clarify some things, have you had any sort of recent unexplained weight loss or gain?
Oof, mama, I wish I need to lose some weight. My wife has been on me every week.
Okay. Do you have any bowel or bladder changes?
No. We're good. We're good.
Okay. And sleeping, you've been sleeping okay?
Yeah, I sleep after about 6 whiskeys. Out.
Okay. Um, so those are all the questions that I have for you today. And then the next step is we're going to do some different testing to see your different motions, if that sounds okay.
Yeah, let's do it.
Okay.
Okay, we're going to talk a little bit more about lumbar stenosis. Ooh. So some epidemiological data typically affects your older individuals, 60 years of age or greater. It commonly occurs in people with spondylosis, spondylolisthesis, disc degeneration, and degenerative arthritis affecting the spine, and slightly more common in men than women. Some typical subjective signs would be neurogenic claudication, which is a hallmark sign, which could consist of some symptoms in the butt, groin, anterior thigh, and posterior part of the leg to the feet. They also generally have fatigue, heaviness, weakness, and paresthesia in the legs. Their symptoms can be unilateral or bilateral. As noticed here, bilateral seems to be more common with central stenosis and unilateral for lateral stenosis. Their pain is normally exacerbated with walking, standing, and maintaining certain postures, and it's relieved with sitting or lying, most notably with supine in comparison to prone. They have discomfort and sensory loss and weakness in the legs. For the bodygram, typical is to have pain in the mid back, but could also be on the left or right. And then, as mentioned previously, having some neural symptoms down the legs or in the front or medial thighs. For your objective, some people might have a positive straight leg raise. It might have some weakness and sensory loss in one or more spinal roots, absent tendon reflexes at the ankle and knee, radiating leg pain. Again, it's exacerbated by standing or walking, absence of pain that's reduced with lumbar flexion, so sitting postures, or as mentioned previously, laying supine. They'll have reduced mobility in the low back, extension more than flexion, and possible hamstring tightness. And typically their neurological exam will be normal, except for some of the sensory and weakness changes. Some key diagnostic features. So stenosis, the diagnosis of it is only really done through MRI or a CT, and even then there's really no accepted definition for what it is. In general, relative stenosis is considered a diameter of 10 and 12 millimeters, and absolute is less than 10 millimeters. In addition to this, you're just looking for a presence and history of the typical symptoms mentioned previously, combined with the imaging to confirm as best as possible. And then also new onset of symptoms and signs of multi-level lumbosacral radiculopathy. Some mechanisms for symptom, we have some nociceptive pain from noxious stimulation, neuropathic pain from ischemia or compression of the nerve roots, and again, narrowing of the spinal canal, leading to increased compression of the spinal cord, and also increased epidural pressure that can be during extension, which is your standing and walking positions. So for treat or refer, we're going to treat first and treat conservatively, and depending on how that goes, you can refer out for imaging, and worst case could be for surgery. Example treatments, we're going to treat conservatively first. So this can consist of some stretching, strengthening exercises for the lumbar spine and hip, endurance exercises, medication, and worst case surgery.
Hey Britt, how are you?
It's Maddie.
I'm so sorry about that. Do you have a twin or something?
No.
Oh, okay. I'm sorry, Maddie. How are you?
I'm doing okay. I have some back pain. That's why I'm coming in to see you today.
Okay. Can you show me where you're having that pain?
Yeah, it's actually like kind of like right here. But the weird thing is like, I don't know if it's related, but I have like this sort of like pins and needles down my leg.
Okay, that's good to know. Is it just on that one leg? Or
Yeah,
both
just
legs?
on my left leg.
Okay. How long has that been going on for?
So yeah, that's another thing. Like I don't remember a specific incident that kind of brought on my pain. I think it's more kind of just gradual. Like a couple weeks ago, I think.
Okay. Are you in pain right now?
Yeah, I am. And I have the pins and needles.
Okay. And if you could rate that pain on a scale of 1 to 10, 10 being the worst pain you've ever felt, 1 being no pain at all, what would you rate it?
I think the pins and needles are probably like a 4 out of 10, and like my back pain is probably more like a 5 or 6.
Okay. And I don't know if you mentioned this, but how far down are those pins and needles going?
Right now it's almost like in my calf muscle. Like it's below my knee, but it's not quite to my foot.
Okay, it's pretty far down.
Yeah.
Is there anything that you found that makes this better or takes away the tingling and numbness?
So as you can see, I'm a volleyball player, but I'm also a student, and so with like quarantine and COVID and all of that stuff, I have a lot of online classes, so I'm sitting probably like 3 or 4 hours per lecture, and like I find that when I'm sitting a lot, it makes my pain worse, so like I'll try to stand up or walk around, and that seems to make it better.
Okay, I can definitely relate to those long classes.
Yeah.
I like that too. Is there anything that you found that makes it worse?
So definitely sitting a lot, like I was saying. But one thing that I've noticed with like volleyball is like, when you're in practice, you're doing drills, and like after you do a drill, you have to go shag all the balls. And like when I'm repeatedly like picking up something and like bending down, I feel like that really brings on the pain in my back and the numbness and tingling down my leg.
Okay, so it sounds like pretty much anytime you're bent forward, either at the computer or playing sports.
Yeah, I think that's it.
Good to know. Is there any past medical history that you'd like me to know about? Any surgeries or injuries from sports?
No, I don't think so.
Okay. And then I just have a couple more questions for you to make sure that I'm the right provider that should be seeing you today. Have you noticed any changes in bowel or bladder function?
No,
Okay. And does this pain ever wake you up at night?
no.
Alrighty. Well, I think that's all the questions I have for you today. So we're going to go through some of the more objective testing, if that's okay with you.
Okay, sounds good.
So first, I just want to see your range of motion. So if you can go ahead and stand up for me. Good. And we'll just put your hands on your hips. We want to keep your hips still and see how far you can lean forward for me.
This way?
Yep, perfect.
Okay. I think that's probably it.
Okay, you can come on back up. Any pain or anything with that?
I think if I did it probably like 5 or 10 more times, I'd probably have pain.
Okay. And let's go ahead and go backwards. So same thing, keep your hands on your hips. Does that change your pain at all?
I don't think right now. It feels pretty good.
All right. And then one more, we're just gonna go side to side. So you're just gonna lean over, trying to keep your hips nice and still. Good. Anything with that?
No.
And then we'll do the other side. Alrighty. So it seems like you feel a lot better when you're in extension, and that's that bending backwards movement. So what I want you to do is what we call repeated extension. So you're just going to do what you did going backwards, and we're going to do that 10 times.
Okay. So just
hands on your hips. Mm-hmm. And nice and slow.
Yeah, this feels good. This is kind of the movement that I do when after I'm sitting and I start to have pain, I kind of get up and like stretch my back around.
And that makes it feel better?
Yeah.
What is this doing to your pain? Do you notice any changes or anything?
Yeah, actually, after you said that, I think my pins and needles is almost like above my knee now. It's kind of like changing position.
Okay, that's good. And you may notice that you're increasing pain in your lower back, but that's okay. As long as we're bringing those pins and needles up your leg, that's the perfect sign that we want to see with this. So everything is looking good. All right, I think you've hit about 10 there.
Yeah, me too.
So let's just reassess and let's see that flexion again. That's that forward bending. All right, you're able to get a lot farther that time.
Yeah.
With less pain with it too?
I would say so.
And then we'll just do one more extension to see where your range of motion is like that. All right, that looks really good. So I think we'll definitely be able to treat you in physical therapy today.
Good, thank you. The next diagnosis will be low back pain with a directional preference. The body diagram for this population will display low back pain as well as lower extremity referred symptoms, which can either be pain or paresthesia. Epidemiological data for this diagnosis shows that the most common directional preference is extension. Females and males have an equal likelihood, and flexion directional preference is more commonly seen in older individuals greater than 50 years old, and extension directional preference is more commonly seen in younger individuals. A patient will come into your clinic with subjective complaints of low back pain with referred symptoms, either pain or paresthesia, extending down their lower extremity. They will complain of specific aggravating or alleviating factors during the subjective history. More specifically, they're going to report a specific preference for activity or movements. So in the case that Kendall and I had portrayed to you guys, I had an extension preference. My symptoms were relieved with standing and walking. Conversely, if I would have had a flexion preference, my symptoms or pain would have been relieved in sitting or forward bending. The key diagnostic feature of this diagnosis is that in response to repeated end range movements into the directional preference or positional load strategies, you'll see that the pain intensity will improve or be abolished, the symptoms will centralize, and or the lumbar range of motion will improve. So like the case we had shown you with extension directional preference, the symptoms will centralize with lumbar extension and peripheralize with lumbar flexion. Conversely, with a flexion directional preference, you will see that the symptoms will centralize with lumbar flexion and peripheralize with lumbar extension. And then lastly, the lateral shift directional preference. With these patients, you're going to see that they will centralize with lateral translational movements of the pelvis and present with an asymmetrical active side bending range of motion, in addition to a visible frontal plane deviation of the shoulder relative to the pelvis. The mechanism of symptoms. So this is a neuropathic type of pain with potential nociplastic mechanisms. As we learned in the PowerPoint on pain physiology with Dr. Kalem, this pain is caused by an altered nociception from a space-occupying lesion with or without clear evidence of actual or threatened tissue damage. Other research that I found included the DISC model, which was developed by McKenzie, which relates to why symptoms centralize, and this states that repeated motions of the spine alters the position of the nucleus pulposus in a way that reduces tension on the innervated portions of the annulus. So this is stating that when an individual maintains a sustained posture, it forces the fluid in the disc to accumulate in the opposite direction. And this activates nociceptors when moving out of the position. So the big question, do we treat or refer? We treat this population as we learned in MSK2. For example, with an extension directional preference, they can do prone press-ups. With a lateral shift directional preference, we can do the lateral shift corrections shown in the picture. And then lastly, with a flexion directional preference, we can have the patient do a knees to chest position.